Hello and welcome everyone. Welcome to tonight's event or today's event titled Medicines Reconciliation, an essential pharmacist-led service to ensuring patient safety. My name is Naman Nguyen and I'm a medication safety pharmacist at Sir Charles Gardner Hospital, a large tertiary metropolitan hospital in Perth, Australia. I am pleased to be your moderator for this event. In the spirit of reconciliation, I would like to acknowledge the traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respect to their elders past, present and emerging. I also acknowledge the traditional custodians of the lands across the world from wherever attendees are joining us today. To begin, a few housekeeping items, please. This event will be recorded and available for review at a later date. I would recommend that you refer back to the slides as we do include a number of useful links throughout for further reading. Please send us your questions throughout the event. Just use the chat question box function. We've dedicated Here's a summary of our program today. I'll introduce the speakers as we go along. You would have already seen our learning objectives. Hopefully we can cover all of these today in a fun way. So medicines reconciliation has long been considered an international priority for medication and patient safety, as highlighted by the World Health Organization's High Fives project in the 2000s and the current WHO Global Patient Safety Challenge, Medication Without Harm. I was pleased to contribute to FIP's Medication Without Harm paper in 2020, and it is very exciting to see the FIP's Medicines Reconciliation Toolkit this year. Medicines reconciliation, as defined by FIP, is a formalized and standardized process that involves obtaining a patient's comprehensive current medication list and comparing it to any medicine that they request or are being given at any healthcare setting in order to identify, resolve any discrepancies according to the standards of medication frequency, route, dose, combination, and therapeutic purpose. On every occasion that a patient presents to us for care, they are expecting just that, to offer them care without causing them harm and to help them to get better. We do not want to cause inadvertent harm which can occur if we do not know what medicines they are taking before their presentation, if we omit or duplicate their medicines, or when we don't communicate any changes that we have made to their medicines when they leave our care. Medicines reconciliation plays a key role in patient safety and achieving continuity of care. Each part of the medicines reconciliation steps or processes is an opportunity for us to optimize the patient's medicines. For example, in identifying which may have contributed to their presentation or enhancing patient adherence to medicines once they leave our care. As pharmacists, we are best placed to lead medicines reconciliation activities. However, we must recognise the role of the patient and carers and also our healthcare colleagues also. Of course, it's all about shared and informed care and teamwork. Our first presentation today is titled Defining and Identifying Concepts of Medication Reconciliation, an International Pharmacy Perspective, and it will be delivered by two presenters, Jonathan and Regis. Dr. Jonathan Pem is a senior lecturer at the University of Sydney School of Pharmacy. He's a well-known pharmacy researcher internationally and has over 70 peer-reviewed publications promoting evidence-based hospital pharmacy practice and improving patient safety. He serves as the Vice Chair of the FIP Hospital Pharmacy Section Research Committee and the Chair of the Society of Hospital Pharmacists of Australia Research Leadership Committee.
Okay, thanks, Naman. I appreciate the introduction and hosting this webinar on medicines reconciliation. I was very excited to see that FIP published their toolkit for all of you here to access. There's the link. And this is a really important patient safety initiative that pharmacists are one of the key players. And it's exciting that we get to present this webinar. But the main reason for our talk was I'll just speak for the next 10 minutes to talk about the definition of medicines reconciliation, because we found there were some differences around the globe, and it's important that all of us are speaking the same language. The World Health Organization stated it was that formal process in which healthcare professionals partner with patients to ensure accurate and complete medication information transfer at interfaces of care. But as pharmacists, you all know that medication information can mean a lot of different things to a lot of different people. When you look at a medication history done by a junior doctor, it can look very different to one done by a pharmacist. And so we wanted to get the pharmacist perspective on what is medication information. It's not clear when you looked at other definitions. The Joint Commission just called them medication orders. So that was clearly relevant mainly to a hospital setting, not other ones. The National Institute for Health and Care Excellence said it included things like name, dosage, frequency, and route of administration. So it gives a little bit more information. But then the Australian Commission also said it included the reason for any changes. So you could see there was quite a diversity in what was medicine information. Is it just the drugs? Is it the indication? Is it the things that have changed? And not everyone was doing it the same way. So on the next slide, you'll see that the one thing they all agreed on is that it is a consensus between a best possible medication history and what's being prescribed or requested by the patient. And that best possible medication history is often put together by at least two independent sources. So there's a picture there, could either be from patients, their medication list, a government database, previous health record, but it could happen at admission or at discharge. Okay, next slide. The definitions that varied, not only was medicine's information different in those definitions, but when we looked closer at it, we found that the definition of medicines varied. Some people thought medicines also meant the vaccination history, and this was before COVID, and not everyone agreed that a vaccination was included in the medicine's history. Other people included recreational drug use. So that again, there was some controversy around what is a medicine. And then for reconciliation, there was debate happening. Is it mainly for hospital admission or is it for other areas of care? As you saw, the Joint Commission really cared about hospital admission, but maybe other areas mattered as well. Some places also said that it has to happen with a medication review. Does reconciliation include a review of medicines or not? And that wasn't clear. In some definitions, it was the same thing. Others, it wasn't. Others talked about communicating changes directly to the community pharmacy physicians, and others talked about providing the best possible medication history to patients as part of the reconciliation. So the scope of practice of reconciliation varied quite a lot in all those different definitions that we found. And so again, we wanted to make an international definition with a pharmacist perspective to do best practice to ensure all our patients around the world are receiving the same level of care. So we put together a publication that you can read more about in your own time, where we've identified and defined the concepts of medicines reconciliation from an international pharmacy perspective that's been published in the Research and Social Administrative Pharmacy Journal in 2019, so a couple of years now. And the way we did this is what we used an international consensus using a modified Delphi process, which I'll go to next. So for those not familiar with the Delphi process, what it usually is that it starts with a facilitator, which was me and Regis, my colleague on the line as well. We put together different concepts of medication reconciliation and tasks, and then we put it to a group of experts. The experts responded whether they agreed or not, but they couldn't see each other's responses, so it was anonymous, and only the facilitator could see what they agreed on. Anything they didn't agree on, we reworded or removed and see if we could get agreement. We did this all online. And then finally, we ended up with our consensus statements. Next slide. Things that we looked at was tasks involved, who can conduct them, when they should be conducted, and who should receive them. We also looked a bit about how to measure it, but it wasn't a large focus. Next slide. So as a whole, the experts either agreed or disagreed with the statements on a 4-point Likert scale. We had 24 experts identified through publication authorship on work related to medicines reconciliation, or they were an FIP member, and that they were responsible for implementing or evaluating a medicines reconciliation program at the time, and they were fluent in English as the survey was facilitated and conducted in English. We had representation from 16 countries, and this worked in a range of settings, including hospital, academia, community, and the pharmaceutical industry. As a whole, our agreement was set to 80%. So you can see here what we did was that if it was less than 70%, we pretty much dropped the statement if we couldn't get it to get above 70%. If it's 70 to 80, we just kept modifying it until we got agreement. Otherwise, if it kept getting bad agreement, we would drop it. But as a whole, the statement we're going to present today had 80% agreement over all those different countries. And it took us about 3 rounds to complete the process. So what the definition that we agreed upon, Anne has pretty much said this in not so many words, but the process of creating the most accurate list possible of all medications a patient is taking and comparing that list against the prescriber's orders. In addition, the patient's allergies, history of side effects for medications, and medication aids are listed with the goal of providing correct medication to the patient at all transition points within the healthcare system. So there are some key points there. We'll just go to the next slide. You'll see that, next slide, sorry. You'll see that we already talked about the 2 sources, that part we already know about. But the things that we've added to it, to those other definitions, is that medicine information includes not just the medicines they're prescribed, but it's also natural health products, over-the-counter. Medicines information is also allergies and previous side effects, which is not clear on those other definitions. And we also found that our group had consensus that it should include a vaccination history for pediatric patients. And now with COVID, I'm sure vaccination history is much more important. Okay. Other things it includes, which wasn't in other definition, is that it was really important to look around the medication compliance. So a reconciliation would also list who was responsible for administering the medicine, whether it was the self or a carer. If any compliance or adherence aids were used or they weren't compliant, all of those things were important information to pharmacists that most other professionals left out of their definition. And then we would also classify those discrepancies as either intentional, unintentional, and review the appropriateness of those discrepancies was agreed upon by our committee. And as at the end, those things would be documented and written to the pharmacist and prescriber. Things that wouldn't surprise you is that we said pharmacists could conduct this, as well as physicians, nurses, pharmacy technicians, and students with additional training. So that was good that came out. Everybody agreed on those. And then those who should get it, there was definitely agreement that's not just admission to a hospital, also included ED visits, emergency department visits regardless of admission, transfer within a hospital at discharge, and also each clinic and pharmacy visit, which was reflected in NAMAN's definition as well. Last, there was an ideal that everyone should receive a medication reconciliation, but we did know that that's nearly impossible from a resource perspective. So we highlighted some high priority groups, such as those aged 65 and older on multiple medicines, those taking high risk medicines, those with renal impairment, critical care or transplant patients, and lastly, patients with low literacy levels were considered the high risk for there. There was discussion around the difference between medication review and medication reconciliation. And as our consensus for our panel, we agreed that they were separate. That medication reconciliation and review are separate concepts, but can and often do occur simultaneously. Reconciliation looking at the differences between what's requested with that best possible medicine history, while the medicine review focuses on reviewing appropriateness of all of the therapy, not just the discrepancies. And I'll pass on to my colleague, Regis. Thank you.
So our second speaker today is Dr. Regis Vaillancourt. Regis is the Director of Pharmacy at the Children's Hospital of Eastern Ontario, Canada. He's also a hospital surveyor for Accreditation Canada. He has served as a board member in different roles, such as the FIP Vice President, Canadian Society of Hospital Pharmacists President, Pharmacists Without Borders Canada President, and the Ontario College of Pharmacists President. He has been recognised as a fellow by FIP, the Canadian Society of Hospital Pharmacists, and the Ordre des Pharmaciens du Québec.
Thank you for this very nice introduction. And next slide. What I'll try to do in my presentation today, I'm going to talk about how did we implement some of the concept that Jonathan and from the Delphi that we got, and what kind of data we've been able to gather to better guide therapy or guide the therapeutic decision. Next slide. So there's really 3 levels of medication reconciliation within the hospital, and the focus of my presentation would be about hospital care. So there's on admission, on transfer between units, and on discharge. On admission, basically, we have a concept here at the hospital that the doctor does their medication history into the electronic health record, but within 24 hours or 48 hours, the pharmacy technician validates the medication history to ensure that there's no discrepancy between the orders that were on admission and the prescription that the patient was taking. If there is a discrepancy at that point, then they refer back to the pharmacist to do the assessment, and then the pharmacist goes back to the clinical team. On transfer from one unit to another, like critical care to the ward, there's a forcing function in the system to force the clinical person to do that is doing the transfer to do reconciliation. And on discharge, also in our system, the electronic health record, there's a forcing function before a patient can get discharged, that the physician has to look at the medication the patient was taking at home and the medication prescribed in the hospital to make a decision for each of these drugs to see if they're going to be prescribed or continued or discontinued. And it is printed to the patient in the after visit summary. So the process that really I want to talk about today, and we've been gathering more information, is really medication reconciliation on admission. Next slide. As I said, medication reconciliation must be completed as a policy statement within 24 hours. And we have an exception, is a patient that gets admitted to a neonatal intensive care unit, as they don't have a medication history. Usually, because we only take transfer from other hospitals, they have history from the patient's chart. So that's the only exception we have. Next slide. So it's basically, go to the next slide. Thank you. So key people involved is again the physician, who's supposed to look at the prior to admission orders from the electronic health record and make a decision, and then use the transfer navigators. The pharmacy technician, again, within 24 to 48 hours, doing an interview with the family, and being proud of that based on complexity and based on the data we've gathered from the Delphi. I can show what would be the impact of this. And of course, reconcile the medication between the admission list and the list of drugs the doctor has prescribed. Next slide. Nursing also has a role to play because they want them to review and make sure that the allergies are up to date, even if the pharmacy technician within 24 hours and 48 hours will review them. And the pharmacist, as I said earlier, is responsible to look at discrepancies. So when the pharmacy technician finds discrepancy, goes back to the clinical pharmacist for them to assess and to discuss with the team, with the clinical team. Next slide. This is the most important, one of the most important slides that in my presentation. So we did an analysis of medication reconciliation per number of drugs the patient was taking prior to admission to align with the Delphi that we talked about. And we noticed the more drugs that you take, the less likely you get to have a complete medication reconciliation in a timely fashion. And it had to do with the workload. And so we refined our process within the hospital to be able to focus on the high-risk patient. Next slide. And what we've seen over time is a significant improvement of the reconciliation of the patient taking more than 5 meds. So by changing the focus, and because we could not do all the patients, we're focusing on the high-risk patient, then we're basically able to get a better percentage of reconciliation in this group. Next slide. Next slide, sorry. We also had another way to validate our medication reconciliation, and basically through our patient patient post-visit survey. And we've seen that we want to make sure that the process was there. And we noticed that the patient do remember being asked in family about the use of their medication. So it's a way to validate both the statistics from our electronic health record and the experience of the patient. Next slide. We went further and actually we document in every patient medication reconciliation who is responsible for who's giving us information. And being a pediatric centers, we know very well that the mother is much more reliable than the father. No offense to the father. So in majority of the times, the mother that we get the information, better information from. Next slide. We also ask the question, who is responsible within the household to administer the medication to the child? Again, the majority of the time is the mother. Next slide. And we've had these two questions to figure out who should we be speaking to about medication counseling on discharge. And again, the majority of the time is the mother that the person we need to talk to. Next slide. We ask about medication coverage because it's a key element of knowing if there will be an issue on discharge. If they prescribe a drug that's not covered, there's no coverage, then there's no point of prescribing it, or we need to find an alternative way to have access to the patient have access to the medication. Next slide. We always ask if the patient is breastfed or not because it has an impact on care and what medication the mother is taking on the patient. Next slide. As we stated in the Delphi, we ask the immunization status. So during this influenza season, we ask about if they received the flu vaccine or not. We also ask them in pediatric if their immunization is up to date. That's a technician that asks this, and it's a yes or no answer. And we also ask them a question about if they had an immunization within the last 2 months. The reason that the immunization within the last 2 months is because we have a process in Canada, the Canadian Pediatric Society follow any side effects related to vaccine. So every patient gets admitted within 2 months. If any pediatric patient gets admitted within 2 months, gets checked, see if it's a vaccine side effects. That's why we're asking that question. Next slide. We are about smoking status of the household, because there's a lot of data that shows if there's a smoker in the household, that patient has asthma, they're more likely to be admitted for asthma. We also ask about cannabis use, since it's been legalized in Canada, and also smoking for the patient himself. Next slide. We also, part in our electronic health record, if the pharmacy technician identify the patient being at low health literacy, then they will make sure the pharmacists intervene on their care to make sure there's smooth transition towards the community. Next slide. You can skip that slide as well, sorry. So this is my point. So the point of my presentation was really to show you how we can use the Delphi system to better target the medication reconciliation process. Thank you.
That's fantastic. Thank you so much, Jonathan and Regis. Our next speaker is Professor Veerli Phulan. She will be speaking about medicines reconciliation in the community pharmacy setting and across transitions of care. Veerli is a professor at the Faculty of Pharmacy at KU Leuven, Belgium. Her research mainly focuses on the role of the pharmacist in the rational use of medicines in the ambulatory setting, on the impact of collaborative practice and of electronic tools on patient safety and continuity in medication management, patient education and counselling, with an emphasis on drug information adherence and medication discrepancies. Veerli teaches communication skills, pharmacotherapy and self-medication, and coordinates different internship programs. She is also coordinator of the master thesis in pharmaceutical care and is involved in postgrad training. Veerli is Vice Dean of the Faculty of Pharmaceutical Sciences of the KU Leuven and former board member of the Pharmaceutical Care Network in Europe.
Thank you. And thank you for your nice introduction and also for the invitation to participate in this meeting. I think it's really interesting. And this has been a topic that I've been working on since, well, I think 2010. And on the next slide, you see why. Yes, thank you, Ruben. So there were like four main topics over the last 10 years, I would say, that helped us to focus on medication reconciliation and on transmural care policy within Flanders, Belgium, where I'm working in. First, there was the harm study. That study was published in 2006, was a study from the Netherlands. And of course, that's very close to us. That was a paper that was really research that was really well done. And that really evoked us that there was certainly a problem with hospital admissions related to medication, and especially with readmissions that were related to difficulties in dealing with medication in primary care after a hospital stay. So that was really a very important study for us, and that resulted in a project developed by our government, or asked by our government, that we've been working on, our team together with the team of Anne Spinnewin in 2009-2010. And the report that we made in 2010, in that report we already wrote, it is important that we invest in good procedures and guidelines for a seamless medication policy where continuity is the main focus. What we discovered in that project was that there were many different initiatives in the hospitals, as been explained now, on admission and at discharge, but there was no clear guideline on how to do it. Every hospital did it differently, and primary care pharmacists were not really involved. What they tried to do was to deal with the bits and pieces of information they got and to help the patient as good as possible, but that is certainly not a way in which we can deliver qualitative care. On top of that, we had a report of IMS in 2015 showing that about 400 hospitalizations per year per 100,000 inhabitants happened in Belgium related to medication. So if we counted that back on the number of pharmacies, it was quite a high number of patients per pharmacy. So that again raised some questions in the community pharmacists, and also some enthusiasm to really work on it. And that was further supported by systematic reviews, and there's only one mentioned on this slide. So if you go to the next slide, all this information helped us really to invest in research on the role of the community pharmacist in transmural care, and more specifically in medication reconciliation. That is in line with what has been written by multiple institutions and also what is supported in some systematic reviews. And I saw a question already on that. Although the evidence, and I will come back on that later on the impact of the community pharmacist is not that straightforward, and I'll explain why that is. Community pharmacists can take a role if they are sufficiently trained, so that we can ensure the quality of medication reconciliation, if they have access to information that is relevant for constructing the best possible medication history, if there is a proactive communication between healthcare professionals and between healthcare professionals and the patient, and there is a fourth bullet that is about collaboration with other healthcare professionals, especially the general practitioner, of course. So if we take all that into account, we can then build programs that help pharmacists to take up that role. Now, I will first explain one specific aspect, and that is about sharing of information on the next slide, before I come to a concrete project that we have tried now for the last 2 years. So what is our current situation in Belgium? In Flanders, we have a system called Vitalink, and it's a digital platform that allows to share information on the patient's medication plan between healthcare professionals and the patient, of course. So you can put one actual current medication scheme on the platform, and that's accessible by the GP, by the pharmacist, by the home care nurse, by the patient. So that's one system we have, but it is not fully implemented. And when it was developed for primary care. And that brings now some difficulties, because hospital pharmacists, for instance, can read the information in Vitalink, but they cannot put back information in the system, which is, of course, a difficulty. They're working on it, but so far it's not working perfectly. There is another project on the Belgian level. It's called VIDIS. VIDIS means Virtual Integrated Drug Information System. The idea is that over some time, we will have always one therapy plan online with all the background information, and that will serve as the basis for a prescription. This is still in development. So far, it's not running. And that's why, and it seems very old school, we have now finally decided to work with a paper envelope to share information between hospitals and community pharmacists. And it's called now the project Green Envelope, and green is because it's about the pharmacist. And I think you can press the button, Ruben, then it will appear. Thank you. And that has now formed the basis for one concrete project that I want to share with you in the next slides. So how does it work? Well, at hospital discharge, yes, the patient received an envelope with, on which it is clearly mentioned, please take me with you to the pharmacy. And that's the idea. The patient brings the envelope to the pharmacy. What is in the envelope? There are the prescriptions at discharge, the actual medication scheme that has been prepared by the hospital at discharge, or at least how and which medicines were given to the patients on the last day of hospital stay. There is on the envelope a code that needs to be scanned by the pharmacist when received. That gives us the data on how many envelopes reached the pharmacy and how many were then treated by the pharmacist. And there was a registration form for the community pharmacist inside the envelope. The idea is then when the pharmacist receives the envelope, there is a pharmaceutical discharge counseling. I will explain later on what that is. And the pharmacist, yes, indeed, scans the code and registers what he does on an information sheet. He registers the drug-related problems, the discrepancies that has been found, and the actions taken by the pharmacy. We had developed, of course, that scheme before, and we would have hoped to do it with the electronic sharing of information, but because it is taking so much time, we finally decided we have to continue. There are all these data that pharmacists can contribute, and that there is absolutely a need to do better than we currently do. So let's just start it and do it on a paper way. Now, the key component, of course, of what the pharmacist can do, the community pharmacist, is then what we call discharge counseling. We start from the information, of course, received from the hospital, but then we have two parts. The first part, yes, you can click, is the medication reconciliation performed by the community pharmacist, and where the idea is indeed to compose a correct and up-to-date medication scheme, not only based on the scheme that is in the envelope and has been developed in the hospital, but also based on information that is in the community pharmacy available, a medication history, a previous medication therapy plan, information from the patient, information from the hospital. And that includes, of course, that reconciliation aspects of pharmacovigilance. But that is, of course, followed by a counseling conversation, and in reality, it's of course mixed, the reconciliation and the counseling performed by the community pharmacist with a focus on correct medication use with involvement of the patient. So if choices need to be made, you do it together with the patients to make sure that what you design is also feasible in practice when the patient is at home. And the whole focus is on self-management support. So the idea is that the pharmacist, and many pharmacists everywhere in the world are already trying to do that, to help the patient after hospital discharge to take the medication as intended and as good as possible, and to support self-management in order to support, of course, adherence, compliance. And to have the information to counsel the patient, we have now designed that old-fashioned way of sharing information on paper so far, while waiting for electronic transmission of information. So this project has started now in one region in Belgium. We have currently, and that was very interesting, and that's why we started, we have new projects called projects on integrated care with a quadruple aim, as you all know, on patient experience, population health, reducing costs, and care team well-being. There are 12 projects spread over the country, and one project is located close to our university in Leuven. And that project, and you can click, Ruben, aims to develop and test new healthcare models, develop alternative financing models, and disseminate new care and financing models to other regions in Belgium. And it is in that region, and that's explained on the next slide, that we started the project about the green envelope. We first started in June 2019. Yes, with 3 participating hospitals in the region, and first only geriatric wards, where we got the support of the geriatric wards, of the physicians, of course, but mostly also of the nurses and the pharmacists, to indeed build a medication therapy plan upon discharge, to put it in the envelope and give that with the patient. So that was the idea, and we were able to analyze the data. Yes, you can go to the results, fine. So what we found is we had some data on how pharmacists worked with the information in the envelope. We found that the time spent was on average 14 minutes, that almost in half of the cases, patients or their relatives visited the pharmacy before they even had a contact with the GP, and on the same day of the hospital discharge. And even 70% went to the pharmacy without contacting the general practitioner before their visit to the pharmacy. So that supports the importance of the community pharmacist in dealing with questions related to medication. In 35%, we found at least one medication discrepancy. And I think in about the same number of cases, 34%, there was at least one drug-related problem discovered by the community pharmacist. 40% of the pharmacists contacted another healthcare professional during the medication reconciliation. It could be someone in the hospital or the GP. And when we asked about the project as such, of course, they were happy with the more information they received now at discharge, but they found and they supported us in that they are waiting for a real discharge letter for the community pharmacist. And that supported earlier findings from previous research that was published last year. And it's on the next slide. It was a paper by Joke Wuits from our group, where she drafted a discharge report for the community pharmacist, and it was built on an evaluation of different reports that have been published in the literature, and also on qualitative data within Belgium. So we're still waiting, of course, for the implementation of such a real discharge letter, but for the moment, the information pharmacists receive helps them to work with the patient on the correct therapy plan. On the next slide, we have the further evolution of the project. So on the right panel, you can see that we have now not only more hospitals, but more wards, and also different wards in the same hospitals have now committed to the project. We have a new layout for the envelope, because there were some confusions in some patients. That was mentioned, I'm very important, so keep me. And then some people didn't want to bring it to the pharmacy because they thought they needed to keep it for themselves. We have now an electronic registration form for the pharmacists, and we still analyze the data. We have further developed education and supportive material. We have developed a 5-step approach for the community pharmacist in doing that medication reconciliation, including the counseling. And that was developed before the FIP booklet appeared. So we now have to cross-check to make sure that we include every step that has also been mentioned by FIP. And we developed supportive materials for nurses in the hospital, a sensibilization poster for discharged patients, and so on. And we're striving for financial rewarding for the moment within that region where we try out new financing models. The pharmacists get some remuneration for the service, but of course the idea is to have that on a longer term sustainable developed within the country. So coming back on that 5-step model, that's actually what we train with a pharmacist in online webinars and communication trainings. The first step is, of course, a kind of intake when you question the patient or the care about the patient himself, of course, why the patient was admitted to the hospital, when he was discharged from the hospital. It could be today, but it could also be 3 days ago. Whether the patient has already had contact with the GP, and whether a home care nurse is involved. The idea is to have a kind of global view on the situation of the patient. And then we aim to gather further information on the medication as such, on the medication history. We collect the data from the community pharmacy software. We check for a medication therapy plan before admission. We check the prescriptions at discharge. We check the therapy plan that is in the envelope, and we ask the patient about any discharge medication pills that the patient has received upon discharge from the hospital. And then in the third step, we compare all this information, check for discrepancies, and check also for drug-related problems, for instance, in medication use by the patient, but also in the prescriptions. It could be drug-drug interactions, adherence problems, and so on. The idea is then in a fourth step that the pharmacist takes action, and depending, of course, on the context and the type of problems found. But at minimum, there should be a discharge counseling, discussing the findings with the patient or the carer, preparing an up-to-date medication therapy plan, including the different sources of information, and sharing that medication therapy plan on Vitalink, the platform that I showed you earlier. And then in the fifth step, not to forget a kind of tailored counseling to the patient or the carer upon delivery of the medication. Of course, what you always should do in community pharmacy. But we found it important to mention that as a fifth step, because if we don't do, we see that people tend to forget, and they make just sure that the therapy plan is correct, but that's not the end. You should also, of course, explain how the medication has to be taken, side effects, adherence, and what so on. So especially on the new drugs, that's very important, and make sure that the patient really understands how to read the therapy plan. We see now that this project gets a lot of attention and positive feedback, and other regions within Belgium want to start with the same concept of the green envelope. Now, one question, and that's on the next slide, that has not been solved yet, and that we, of course, very interested in, is in how to move it further in a sustainable way. And what we now will do over the next months is try to expand in target population and in regions, but also to develop next levels of the service and, of course, of the flow of information exchange that should be electronically. And then I come to the point of research. We want to research, of course, the implementation process. How is that implemented into practice? What is exactly the role of the community pharmacist and the outcomes of the service? And that's the question that is not being answered. And to end my contribution, I want to focus now a little bit on these outcomes of the service. When you want to measure the impact of any initiative related to optimizing medication use at discharge, it's very difficult to know what to measure. And we have seen that there are many studies aiming to prove that impact, but they all measure different things, and that hinders comparison between different studies. So it's still difficult to say what the exact impact is of the different interventions that have been tested. And that's why we have, at the level of PCNE, so the Pharmaceutical Care Network Europe, built a kind of research group in which we now are developing what we call a core outcome set for any intervention studies aiming to optimize the medication use of patients after hospital discharge. And I'll show you on the next slide how we did that. We started by, of course, putting our protocol on the COMET initiative. So COMET is an organization that supports people in developing such a core outcome set. So if you want to read more about this core outcome set, you can go to the COMET website and find the initiative. And then on the next slide, you will see that the first step was exactly a systematic review. Yeah, thank you. That we did last 1.5 years. We found 76 articles that met our focus, with overall 79 summarized outcomes. So there were many more outcomes measured in all these studies, but we could summarize them to 79. And I will explain on the next slide in which categories we put them. There was a top 5 that I've put here on the slide: the number of readmissions, mortality, and so on. This slide indeed shows the 5 different categories that we found within all these outcomes, and we put them together a bit according to the ECHO model, but also to other models. You see economic impact and resource use. People have measured healthcare costs, healthcare utilization, unplanned healthcare utilization, follow-up healthcare utilization. Pathophysiological manifestations are the physical condition of the patient, the psychological condition, adverse events. Life impact has been measured as impact on the patient, but also impact on family and caregivers, and impact on healthcare professionals. And of course, a lot of outcomes related to medication, medication adherence, drug-related problems, medication prescribing, and medication information. Mortality has been measured, and more specifically also drug-related mortality. So we cannot say we have to measure these 79 outcomes. That would never work in any study. So that's why we are currently performing a Delphi process, and it's the University of Basel who takes the lead in this together with our university and different other countries in Europe. We are now in the process of developing the panels in each country. So in each country, we aim for 10 panelists in each group, 10 healthcare professionals, 10 patients, and 10 what we call experts, people on more governmental level or a policy level. And we hope to have a 2 or 3 round Delphi process where we will ask all the panelists to rate each of the outcomes according to the importance for them in studies aiming to show the impact of initiatives in order to optimize medication use at transfer of care. So this is currently ongoing, and we hope to end up with a core outcome set by summer, and of course then to publish it so that it can be used in different countries by different research groups, and that it help and with the hope to show indeed the impact of the initiatives to improve medication use at hospital discharge, and of course then to sustainable develop services by community pharmacists, by hospital pharmacists, by GPs, and make sure that every partner can play his role in that regard. So thank you, and we're open for questions at the end of the session.
Thank you so much, Vili. Just reflecting on your presentation, I just wanted to highlight 2 points. I think it was really important that you talked about outcomes and impact. Sometimes we think of MedRec as sometimes a process that we do kind of automatically, but it's really important to think about the impacts that it has on patients, their family, and us as healthcare professionals, especially when things don't go quite right. Secondly, I guess MedRec is synonymous with transitions of care and continuity of care. So we definitely can't do it without our community pharmacy counterparts. So it's really exciting work that you're working on now.
Thank you.
So to move on to our next presenter and our final presenter, Gonzalo Souza Pinto is filling in for Matthew Hung. Matthew is unwell, so we hope he gets better. Gonzalo is the lead for practice development and transformation at FIP. He promotes innovation and advocates for the value of pharmaceutical professional services in the areas of responsible use of medicines, in strategies for the prevention and management of chronic non-communicable diseases and infectious diseases, including vaccination services. He produces publications and tools to support the work of FIP member organisations in advancing pharmacy practice in their countries. He'll be presenting on the FIP toolkit today.
Thank you very much, Naman, and to all my previous speakers in the panel for the excellent presentations. May I have the next slide, please? As Naman was just saying, Matthew Hung led the authorship of this toolkit by FIP, and he was meant to be delivering this presentation today, but unfortunately he was unwell, so I'm stepping in to make the presentation. But I wanted to acknowledge Matthew not only as the author of the slides, but also as the lead author of this publication. Matthew is a clinical staff pharmacist at St. Mary's Hospital in Montreal, Canada. Next slide, please. Also, I would like to highlight the authors of this toolkit. And as I just said, Matthew was the lead author, but we were also supported by a young colleague from Nigeria called God's Gift Iwendi, to whom we are very thankful. And I was sort of editing and co-author of this publication as well. But why did FIP produce this toolkit on medicines reconciliation? We did this as part of a strategy, a broader strategy to focus on improving patient safety. It's really a key priority for FIP and aligned with WHO's priorities as well. And we know that the global burden of medication errors is incredibly high and very important for patient care, and therefore pharmacists really are called to play a role in avoiding harm from medicines use, and therefore FIP has published not only these toolkit and a previous one on medicines use review, that was presented last week, but also a reference paper on patient safety that provides more extensive evidence and studies and best practices on how pharmacists can contribute to improving safety in the use of medicines. But just a few indicators of why this topic is so important. A Cochrane review found that nearly 56% of patients are at risk of having at least one medication discrepancies at transitions of care with standard healthcare. This includes, of course, as the previous speakers have mentioned, the transitions of care can include at admission to hospital and at discharge, but also within the hospital setting, the transitions from emergency department to wards or across different wards, but they can also happen in the community because patients visit a GP and other medical specialists, for example, and they may get medication from various sources, also their own self-medication. So an important role pharmacists to look at the overall list of medicines that the patient is taking and identify any discrepancies. We also know that in the United States alone, at least one death per day is caused by medication errors, and that more than 40% of medication errors are thought to have resulted from inadequate reconciliation during transitions of care. Thank you. As also previous speakers have mentioned, and the moderator at the beginning of the session, the World Health Organization also started prioritizing patient safety in 2007 by launching the High Fives project that addressed the challenges related to patient safety. And therefore, since then, WHO has launched patient safety challenges, and the current one, let's say, it's a 5-year challenge with a series of objectives, was launched in 2017 and is called Medication Without Harm. And the goal of this challenge that WHO launched is to reduce medication-related harm by 50% within 5 years, meaning by 2022. Namely in high-risk situations in patients with polypharmacy and at transitions of care. High-risk situations may include, for example, high-risk medicines or medicines with a narrow therapeutic window, or patients who are on polymedication, for example. And I've included a sentence from a WHO officer, Sir Liam Donaldson, on patient safety, that I think that is really sort of sobering in terms of the impact that this has. And he says that over the years, he has spoken to many people who have lost loved ones to medication-related errors. Their stories, their quiet dignity, and their acceptance of situations that should never have arisen have moved me deeply, deeply. And it is to the memories of all those who have died due to incidents of unsafe care that the Global Patient Safety Challenge on medication safety should be dedicated. So we're talking about avoidable harm, avoidable deaths related to the use of medicines. And of course, as experts on medicines and their use, pharmacists are really called to play a role in improving the safety of that medicine's use. Next slide, please. So, as I was mentioning, in August 2020, FIP released the reference paper to showcase the potential of pharmacist interventions to promote medication safety. This document also adds to previous advocacy efforts by FIP on this issue, namely by speaking at WHO meetings on behalf and advocating for this important role by pharmacists, also with our colleagues in other health professions at the World Health Professions Alliance. And we also issued this reference paper was the basis, was sort of collecting the evidence to support a statement of policy by FIP, which was launched in September 2020 on the role of pharmacists in patient safety. And then we produced 2 shorter toolkits, one on medicines use review that was launched in December, and another one on medicines reconciliation that we launched in February and are presenting today to you. These are shorter, leaner publications than, of course, the extensive reference paper on patient safety. And the point of these toolkits is really to support practice change and the implementation of these services across FIP member organizations and around the world. Next slide, please. Thank you. So this toolkit on medicines reconciliation builds on previous international efforts to define the concept, and this was addressed previously by Jonathan and Brigitte, who were major contributors to this toolkit through the paper that they presented, and including this study on the various definitions that were available, and also provides a step-by-step process and practical implementation tools for pharmacists to adopt and implement this service within their practice. It was developed with incredible expert inputs and contributions from the community pharmacy section of FIP and the hospital pharmacy section of FIP. Has been addressed by previous speakers and by Naman, the moderator. This issue is really wherever medicines are used and need to be reconciled in terms of avoiding discrepancies. So it's really across all practice settings that are dealing with patients and with medicines use. Next slide, please. So FIP proposes a definition of this service in this toolkit that is the systematic process of curating and compiling an accurate and up-to-date list of all kinds of medicines a patient is using at all transitions of care to eliminate medication discrepancies and control any existing or potential medication errors. FIP fully supports the definition that was the result of this Delphi consultation that Jonathan presented before. And this definition really does not collide in any way. It's perfectly aligned with that one. So next slide. Thank you. This toolkit also includes some evidence on the clinical and economic impacts of medicines reconciliation. We saw that one of the questions that was addressed by one of the attendees today asked about where can they find links or references to the impact of this service so that they can be used in advocacy work at country level. Well, this toolkit provides some of them, but as I said, this is a lean toolkit whose aim is really to support pharmacy practice in adopting this service. The reference paper on patient safety provides a more extensive review of the evidence, but some of the studies that are included on this toolkit on medicines reconciliation, for example, one study found that 83% of the discrepancies identified while conducting medicine history had potential to harm the patient. So definitely something needs to be done about these and resolving these discrepancies. And researchers in the Netherlands found a significant reduction in the number of potential adverse events or adverse effects after a hospital discharge due to medicines reconciliation and patient education. And another interesting study focusing more on the economic impact of medicines reconciliation, that makes the case for why hospital managers or pharmacy managers should invest in pharmacist time in allocating time to provide this service, is that by investing 39 euros in clinical pharmacist time could save as much as 340 euros in medical care at hospital and in primary care, in addition to the administrative costs. Next slide, please. So some of the key elements that constitute the medicines reconciliation process, and I don't want to go too much into detail because I would be repeating some of the concepts that have been presented by previous speakers, but some of the key elements that are important for the process include, of course, building an up-to-date, accurate and complete patient medicines list called the best possible medication history. Also identify any clinically relevant patient information such as allergies, previous medication, events, non-prescription medicines that may be used by the patient, or even complementary and traditional medicines that may be used as well, and other events that may be clinical immunization status, as was described by Regis. And then that a standardized and structured process is adopted to build this list and to identify the discrepancies. That the process is integrated into already existing process for medication management and patient flow, meaning that whenever a patient is transferred to a different ward, for example, or discharged, or when a patient presents at the pharmacy with a profile of multiple prescribers or a polymedication profile, that this is really almost considered as a standard part of the process, that the medication reconciliation needs to be done at those steps as part of the normal flow and management of patients. There's also an important element, which is the shared accountability between the pharmacist and other health practitioners with regards to medicines reconciliation, because it's not about establishing a guild or policing service, but really we are all responsible for the care we provide to the patient as a team. And of course, it is important to involve the patients, their families, their caregivers, and on all other allied health professions that may be involved in the patient care. And finally, to obtain the consent from patients or the assent from their families to provide this service. Next slide, please. So also to build up the best possible medication history, as Jonathan has mentioned, it is important to use at least 2 different sources of medication history. That could include an interview to the patient, access to medication records or clinical records. It could include interviewing the caregivers or the family, or the medication history or files in the pharmacies themselves. So the more sources of information that are used to build the medication history, the more accurate it will be and more up to date. Also, to identify the discrepancies, these would include omissions or additions or duplications and other discrepancies, like in terms of the frequency or the route or the doses of the medicines that have been prescribed before the patient is admitted, for example, and then newly prescribed when the patient is admitted to hospital, for example, or visits a new doctor or prescriber. And then, of course, to reconcile those discrepancies, including the unintentional or intentional discrepancies. And of course, unintentional discrepancies can be errors that occur when a medication is added or removed from the patient's medication list. But also intentional could be someone who is consciously prescribing a medicine to a patient, but did not realize, for example, that a patient was already taking another medicines for the same indication or for the same purpose, and such errors that can occur as well. And this can be followed by a medicines use review to do a more in-depth analysis of how a medicine is being used and the relevance of that medicine within the general medication plan for that patient. And this, of course, can be done, as we mentioned, in hospital, community, and outpatient settings whenever the conditions are met for the provision and the delivery of this service. And an important message that the toolkit also provides is that the service is important to provide it also, and can be provided in low resource settings. And we call it low resource settings because this can include either low and middle income countries that may have lesser resources in general, but it can also be in a smaller clinic or a smaller hospital or a smaller pharmacy in a rural area, for example, that may have fewer human resources or fewer pharmacists' time to provide this service. So it is important to understand the relevance and the need for the service, and to assign the resources that are possible within the setting that is the services being provided to this service. And perhaps Resources also include technological devices, software, hardware to facilitate and support the provision of this service, but which might not be present in some countries or some practice settings. But even a paper-based medication history can be compiled by interviewing the patient and the family or caregivers, and using that list, identifying the discrepancies, intervening to resolve the discrepancies, and then giving a copy of this to the patient so that they can share it with other healthcare providers, for example. So it is important to acknowledge that low resource settings may have additional barriers to provide this service, but that the service itself is valuable and important and is mostly based on the expertise on medicines. So it's mostly a cognitive service that can be provided despite the barriers that may exist. Next slide, please. I really want to spend a lot of time on this one because this has been addressed by previous speakers. The target moments when medicines reconciliation is key, and also the priority patient groups. And this is also linked to what I've just said about the low resources, because it may be necessary to prioritize patient groups that will definitely need a medicines reconciliation. And when the resources do not allow to cover all the patient groups that we would like to provide the service to, it may be necessary to prioritize the moments or the patient groups that will receive it. But and this exercise is just as important. Next slide, please. And so with regards to the implementation of the service, we have listed in this toolkit some of the challenges that may be encountered. So anyone, be it an organization or an individual pharmacist who is planning to introduce the service, can consider these challenges and prepare for them. And this could be the difficulties in obtaining a complete best possible medication history, for example, or challenges related to interprofessional collaboration. Some of the members of the team may consider these or regard it as some sort of policing or an intrusion or on their own practice and their own criteria. And so it's important to build relationships of trust and to share this with other and to build those relationships and saying that this is really for everyone's good and especially for the good of the patient and to ensure patient safety. Also the lack of resources that we have considered before. In terms of also some considerations for the successful implementation of the service, we provide some guidance in terms of, okay, we need to, as the question that was raised before mentioned, we need to collect the evidence, the research that has been developed to analyze the impact of this service, but also to develop policies and procedures and also an action plan for the monitoring and evaluation of this service. So there's an additional guidance on these topics within the toolkit itself. Next slide, please. And finally, as a toolkit, it includes some tools, some forms that can support you in adopting this and implementing this service, with the key elements that should be part of it, whether it is a technological software tool that supports the service, or if it is a simple paper tool to support the service of medicines reconciliation. So we list a number of elements that are important to collect the information on. And next slide, please. And then a form that, of course, it's a table that lists medicine, the format, the dose, the frequency, the route of administration, and other fields that need to be completed in order to obtain this best possible medication history. And it provides an example of how, for example, this form could be completed and used. Next slide. So the toolkit really serves as a framework for implementing the service and includes some of the tools that can be either directly used as they are or just adapted to what you have and what may be the needs of local practices. And the research efforts and the data from implementing this service can really contribute to national and local developments of pharmacist-led medication reconciliation, and therefore it is important to record the impact of this service when you consider implementing it and offering this service. So it really represents an integral component of pharmacist-led services to tackling medication-related harm. Thank you. Next slide. Yeah, that was it from my side. Back to you, Naman. Thank you very much.
Thank you so much, Gonzalo. And what I'm hearing a lot is about resourcing. So I know that everyone struggles with low resourcing. It doesn't really matter what country you work in, but resourcing constraints are all relative, really. What I could probably offer is that when we feel that we are under-resourced, who can we tackle? We have limited number of pharmacists, limited number of doctors, etc. But how I think of it is, how can we engage the consumer more? How can we teach them and engage them about MedRec so that they are very savvy about it? They demand that they have their medicines checked when they come into a hospital or a clinic and so on. So I think that's another approach, is to get the patient and their carers wanting to have a MedRec done anytime that they move from transitions of care. In that way, they invested in being part of the MedRec process, to contributing to make it easier for us to do our part, and possibly that could help with a resourcing perspective. So what the next part of our session is a Q&A session. So we've had a lot of questions coming through on the chat. We've answered some of them, but if you feel that your questions are still burning, please keep sending them through. If you've got any questions directed at specific speakers, please also let us know. Are there any questions that the speakers might have for each other?
I see a question, for example, from Gladys G, saying that one of the priority patient groups is those over 65. And she says, I guess that would be all things considered, since, for example, if you're on a geriatric ward, everyone will be above 65. Well, it really, I think that also depending on the setting where you are practicing, if you're focusing on intensive care, for example, or a geriatric ward, then most patients would require medicines reconciliation, and this would be particularly important for the type of, or the patient profile that you're attending to. So I think it will also depend on the profiles of the patients that you're dealing with, and the type of care that they are requiring. And Nama, if I may address another question that was also included on the chat function, which was related to whether pharmacy technicians would be competent to provide medicines reconciliation. I think that the other colleagues on the panel may comment on that as well, but there's different steps on the medicines reconciliation process, and especially where resources are a bit tighter. For example, pharmacy technicians may be involved in compiling the best possible medication history, of course, after receiving the appropriate training for that, and to identify all medicines that should be covered and all elements that should be covered in the best possible medication history. And then pass on this task, this list, onto a pharmacist to identify the discrepancies and resolve them. So I think that this can be really a collaborative effort. And also we need to consider that pharmacy technicians may have different training and competencies in different countries. So I think that in order to answer that question, whether they can participate in this process, we would really need to understand what is the profile and of competencies and the training that pharmacy technicians receive in each country.
I just want to add, we've been doing this, having pharmacy technician doing medication reconciliation for about 9 or 10 years. It's been quite successful as long as you follow the process, meaning that, again, as you said, Gonzalo, that the patients, the discrepancy get referred back to the pharmacist for evaluation. We also empowered our pharmacy technician to reconcile drugs. I'll give you an example. Patient is on amoxicillin at home, get admitted as on ampicillin IV. It's 2 different drugs, but they don't need, this is not considered a discrepancy because it's a continuation of the treatment that the patient has received at home. So quite successful if they're well trained.
There's an interesting question online from Irina about confidentiality. Irina works in Armenia, and she's asked about providing examples of approaches, laws, regulation guides about pharmacists seeking and asking and recording information about patient health. Pharmacists ask such information, however, recording it can cause issues with confidentiality. Even asking to sign a consent will not help.
So in Canada, in my hospital, we don't require a signed consent. We require a verbal consent from the family. And when we phone the community pharmacy to reconcile the medication history, we also indicate to the pharmacist that we have consent from the family. And we document this in the patient profile that we have obtained consent. This has caused some problems in our mental health patients where we do not get consent in many occasions for them to contact their pharmacy or them to give us a medication history, but we deal with it. That's why we never achieve 100% medication reconciliation on admissions.
I'll just add to that. That's a really good point. In some countries, pharmacists don't even have the rights to access patients' notes, let alone document in it. And that's a real barrier to having pharmacists more involved in patient care. I would say that you're absolutely right. Unless those regulations or policies are changed, this can be a very difficult position for pharmacists to be in. But it's one where usually the issue is less around patients. The patients aren't really the ones who are promoting that pharmacists don't look at it. When they become part of the health system, a lot of work shows that they just expect this to be happening. They expect medicine's information to be correct and to be transferred between providers. It's more a position of policies not being reflective of that reality. So I do acknowledge the difficulty that you have there, and that's something that really does need to be addressed for this to be moved forward.
There's a question about coronavirus. We changed our process because of coronavirus. We used to do face-to-face interview between the family and the pharmacy technician. And since March last year, we've been doing phone interviews. And actually, this seems to be working as good or almost as good. However, our statistics went down because some days we've been extremely busy at 125 occupancy in the hospital. So then our statistics go down as far as efficiency.
That's interesting. I think coronavirus has made us become more creative in what we do. It's not always about face-to-face to patient as well. There's a question about the order in which MedRec is done on discharge. The question is MedRec being done before or after prescription filling. So obviously it will be more ideal to have the MedRec be done before the prescriptions are filled. the question was any thoughts about the value of a medrec post-script filling. So I guess any medrec is better than none. And obviously you would want to get it right before the patient goes home or leaves care or whatnot. There is a value in doing a medrec or a medicines review as soon as possible after a transition of care. So for example, within the first few days after a patient leaves hospital. So I do believe that a medrec, even if it's not done at the point of discharge, is still a valuable one, where you can try to shorten the gap between when a discrepancy may have been made, an unintentional one, and when that could be caught and rectified so as not to cause harm for the patient.
Thank you, Naman. I fully agree with that, and actually that's the situation of the community pharmacist. I showed that in our study, almost half of the patients went to the community pharmacy on the same day after discharge, but the other half, of course, comes later. And then there is indeed a kind of gap between the discharge and the medrec. You can suppose that something has happened in the hospital, but it's certainly not true for every patient at every discharge. So that's in fact the situation that is described here by Warren. But still, there is an important role to play, absolutely. And also when the patient is already home, gets confused with his medications that he used before the admission, maybe there are some issues, problems arising, and yeah, that's the right time, I think, to discuss with the patient the actual therapy plan and to make sure that everything is clear.
That's definitely the case. I mean, when patients are discharged home, they're bombarded with so much information. And if you don't get the time to talk to a patient about their medicines, particularly about the changes, and if they're not, I guess, confident about those, they'll just resort to what they were doing before they came into your care. So it's really important that our community pharmacists, when they do pick up these issues, whether it's a day or 2 days afterwards, is to try to speak to the hospital. I know that's not always the easiest thing to do, but we do obviously have instances where we chat to our community colleagues and we can rectify the problem, whether it's just identifying that it was an unintentional error or that it was intentional, and have a plan to move forward.
And I think it's important that your electronic health record facilitate this process. As I mentioned in my presentation, we have Epic, and Epic, we build it in such a way that on discharge, before you can write a prescription, or as you're writing the prescription, you have to reconcile the list of medication the patient was taking at home and the one taking in the hospital. And the decision for each of these drugs gets printed in the after visit summary. So the patient has a record of the decision made on discharge by the clinical team. If you don't have it, then that's where the discrepancy increase significantly. This information can also be shared with their pharmacist, and can also be shared with their physician as well, the after visit summary. I do have a community pharmacy that I'm responsible for, and they do have access to the whole electronic health record to validate question when they look at some prescription, because it's very difficult when you only have a prescription, you only have the whole story to make decision about the validity of a prescription.
There's 2 questions online about the money side of things. So the first question is about the data about $10 saved for every dollar invested in a pharmacist, assuming for medrec. Would any of the other speakers be able to comment on that? And the second question is about remuneration for medrec.
I can probably speak on the hospital side of it, but really probably be better positioned for the community side on remuneration. And I agree with, there's good data to show that investment in pharmacists has a good return on investment, that we do prevent serious medication related harm. But I'm also conscious that many healthcare systems are stretched from a budget perspective, and money spent on us or on pharmacy is money taken from other services. So unfortunately, I would say that just saying you save $10 doesn't put into account the other priorities that are being stretched upon the healthcare system. And so what's really important is that you have a pharmacist at the executive table talking to the C-suites, the chief director, to have a chief pharmacist, not just a director of pharmacy, but a chief pharmacist who talks on that C-suite executive level. Because if you don't have a pharmacist championing medication safety at the executive level, then often this data of $10 for every dollar is not heard or not considered. And I think that that voice or that position of advocacy within the hierarchy of a hospital system is very important, and it needs to be advocated continually up there. So that's how I'd respond to that.
What I put in the chat, sorry, go ahead.
No, I try to respond as well. I think in any case, for the community pharmacists worldwide, we will have to shift away from remuneration per package or per pill or whatsoever, I think, and have remuneration more oriented towards care than product. And this could be one of the types of services that could get remunerated, but I think it's only in a very limited number of cases where it's actually happening. What we have in Belgium that might be interesting for people worldwide is we have a new system implemented in the community pharmacy, and it's called reference pharmacist. It's comparable to what you call your GP, is your reference physician. And in Belgium, it was the case that the GP gets per year a budget per patient that is on his list and whom he is taking care for. And that a similar system has now been integrated in community pharmacists. So for patients in specific groups with a specific number of drugs, we can invite patients if they agree that we are, as a community pharmacist, their reference pharmacist. And if the patient agrees, the pharmacist gets a budget of about €30 per year to make sure that the medication therapy plan of that patient is always actual and up to date. And so it's the responsibility of the pharmacist for taking care of medication of that patient. So, and it's an extra remuneration on top of course, what a pharmacist would get from filling the prescriptions. And that, for me, was a good, or positive evolution, because it makes clear that we do more than just, selling medication, if you would say so. So here and there in the world, there are some positive evolutions in that regards.
And then to talk about the Ontario, my province, where I work, the pharmacists get paid to do a medication check. It's called a med check, and they put the link to this. And one of the criteria to get reimbursed for a med check is a patient that got discharged from a hospital within 2 weeks. And I believe they would get paid something like $25 to do that medication reconciliation. And they have up to 2 weeks to do it. Have a look at the link. It has a lot of details how to conduct a medication reconciliation. Sorry, it's called a med check, to be called a med check.
Thank you, everyone. In the interest of time, I think I'll wrap up the questions. Thank you very much for engaging in the question and answer session. I think, as you can see, we're all very passionate about medication reconciliation, and it's very heartening to see. So to conclude, we've heard today that medicines reconciliation is very important for patient safety, of course. It's a way to ensure that we take a strategic process to do no harm for the patient, and also to add value to the patient's care episode or journey. Remember that it's a dynamic process. It's a best possible medication history. It's not a perfect medication history. We can do our best, add to it, add more information as we find out more, keep it going for the duration of the patient's episode of care. Make sure that we listen to the patient and the carer knows so much about their own medicines. Get them engaged in the process so that when they leave your care, you are more confident that they do know what is happening with their medicines and how to manage it. It's really important to communicate your findings, concerns, and recommendations. There's no point doing MedRec and putting down your concerns or your suggestions or recommendations on a piece of paper. It's about communicating with our colleagues, especially our prescribing colleagues. If you don't feel very confident with medicines reconciliation, or if you feel that you have, I guess, want to take a more active role in improving your own medication reconciliation skills or that of your colleagues, there's plenty of resources out there to become more skilled. The FIP toolkit is a really great place to start. And obviously you've got a community of pharmacists around you as well that are obviously speaking the same language and wanting to do the same thing, which is quite amazing. I guess, thank you very much for your time. It's a real treat to be able to speak to a group like this across the world about medicines reconciliation for a good hour and a half. It's a real treat. It's really important work that we need to keep going with. So thank you. Keep the conversation going after the event. Connect with us and do go and have a look at the FIP resources. They're great. Thank you, everyone.
Thank you very much. Have a good day.